So my name is Dr. Richard Huynh. I'm one of the pulmonary and critical care doctors. I'm still practicing and a huge supporter for AB 1400. I might try to do the best I can, following in the footsteps of all these amazing people that you see in front of you. One thing that I wanted to say was, this has been, and I've said this multiple times, this has been probably one of the most challenging years of my life with the pandemic and everything that we're going through. And, we've, as healthcare workers, frontline workers, we've been put in a position so often this year where we are unable to care for each person to the best of our abilities because of their insurance status or because of their lack of insurance or for whatever other reason. We get put in these positions. And, when we go through medical school and all of our training, we're always taught, and this is something that I believe everyone in the medical community holds very dearly, is that you treat every single patient like they are your loved one. You treat everyone to the best of your abilities. And unfortunately, time and time again, we are unable to do that. And particularly during this year, it's been so prominent because of the pandemic and the situation that we're in. And, as the year has gone by, as this year has progressed, the amount of burnout that I see, not just from physicians, but from nurses, respiratory therapists, x-ray techs, you name it, from top to bottom, we see it so much more now because people are they're fed up, they can't work the way that they want to work. And so, one thing that you have to keep in mind is that all of that will be so much better with AB 1400. With Calcare, you'll be able to treat every single patient like they're your loved one. You'll be able to give them all of the benefits and the long-term care and all of the rehab that they so deserve to get better from whatever illness, whether it be from COVID-19 or whether it be from cancer, whether it be from a heart attack, right? And so when people ask me, how are we going to be able to take care of all these people without insurance, blah, 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 blah. Well, guess what? You're going to have a lot more providers here. You're going to have people who enjoy to work, enjoy to see every patient on a daily basis, and don't have the burnout that we suffer from today. So the medical community is just going to become so much more joyous place to work in. We're not going to have to worry about, all these other issues. That's one thing that I wanted to chime in about.
And you said that the people that are making these decisions of what you can give your patients are people who have not talked with your patient, not seen their chart.
I'll answer your question with a story. As you know, I always like to relate my own personal experiences with patients to kind of illustrate what happens. So about 2 months ago or 3 months ago, I saw a patient and we made a diagnosis, and she needed to be started on a very specific medication. And I knew that this was an expensive medication. I knew that it was something that oftentimes is very difficult to get prescribed and to have the insurance companies pay for. So I did my due diligence. I wrote the most complete note that a person can, illustrating why she needs to take this medication, what sort of benefits she'll get from it. I added links on my note to primary medical literature, justifying, sort of my rationale, and essentially saying that with this disease, this is standard of care, this is what she should be taking, right? And of course, I prescribe it, and 2 weeks go by, I call the patient, I said, hey, did you get the medication yet? It's a medication that needs a special pharmacy, so you'll be delivered the medication. He says, no, I haven't. So I said, okay, let's, I knew this was going to happen. So I said, okay, we'll follow up on it. So we call the pharmacy. Pharmacy says it hasn't gotten insurance approval yet. I said, okay, it would have been nice if you told me this, but that's fine. And they said, well, sometimes it takes them a while. Said, that's okay. And so then, we called the insurance company. We said, what's going on here? Oh, it's still going through the approval process. This will take some time. I said, okay, well, keep us informed. Let us know. Another couple of weeks go by. Call them back again. and each time I make a call, it's probably about anywhere between 30 to 45 minutes of wait time each time. Call them again, what's going on? I have the authorization numbers, I have the patient information, and I go through the whole process again. They send me through the phone tree. And once again, I finally get to a real life person and they said, oh, it hasn't gone through the approval yet. We'll let you know in 72 hours. I said, okay, 72 hours go by. I hear nothing from them. I call them again. Another 45 minutes spent. And finally I get a real person again, and they say, oh, your medication is not approved. And I said, why? And they said, well, you're going to have to do, I can't speak to you about that. You're going to have to talk to they call it a peer-to-peer. You have to talk it to someone who's authorized to discuss the case with you. And so let me set up a time. I said, this person really needs this. They're very symptomatic. We need, they're not taking anything for their disease at this point in time. I said, okay, we'll set up an urgent peer-to-peer. I said, okay, so another 72 hours go by. I hear nothing from them. I call them again, and they say, oh, sorry, we didn't get back to you. Your peer-to-peer scheduled on a later date. They give me the date and time, which happens to be another week later. So now I think it's been about a month or so that's gone by. Patient still doesn't have any medication. She's calling me saying, what's going on? And I'm saying, I'm sorry, we're going through this whole process, right? So finally, I talk to the peer-to-peer. I tell them, all the patient information. I tell them all the medical literature that I've gone through, what her diagnosis is, how does she qualify for that diagnosis? Everything's laid out for the person. They said, you know what, this is beyond my scope of practice. So I'm gonna have to talk to my senior advisor. So I said, okay, can you just connect me to your senior advisor person, your pulmonologist, and I can talk to them and they'll understand what I'm saying. They said, okay, sure, we'll get back to you. Another couple of weeks go by, same process goes over again. Finally, 2 months after I wrote the prescription, we got approved. I made 0 changes to my note. I told them nothing new, nothing had changed. Everything stayed the same. It took 2 months for this poor lady to get the medication that she needs. That means 2 months without treatment. This is not uncommon. This happens very often. I knew this was a potential of happening. And it would have taken longer if I hadn't already put all of that information in my note from the get-go. It would have been 3 months or 4 months. But this is all the time. So yeah, when we write a prescription, someone who's never seen the patient can deny it. Someone who may not even be a pulmonary specialist, so I'm a specialist, someone who doesn't even have the type of training that I have can deny it. And then the funny thing is they'll always say, well, can you take XYZ medication instead? And it'll be completely like not even the same medication. It wouldn't even be in the same, category. But that's how they want to work, right? They want to give you the cheapest medication so that they don't have to pay for it. And because they don't really care, but that is what happens.
That is unbelievable. I cannot believe how hard you had to fight. Go ahead, Dr. Huynh.
I forgot. So in the meantime, my patient, I forget, we got approved 2 months later. At about a month and a half, my patient actually went out and bought the drug from Canada with her own money. Things you have to do for your health, right?